Good evening and welcome to our talk on how to stay healthy and injury-free from youth sport to aging athletes. I'm Fiona Roach. I'm the Business Development Manager here at the Sports Surgery Clinic. For any of you who don't know us, we're a private orthopaedic hospital. We treat all orthopaedic and sports medicine injuries. We're about 10 minutes from Dublin Airport. Now, we have three speakers tonight. We're going to start with our first speaker, which will be Luke Hart. Each speaker will join us after the presentation to do a live Q&A. So you'll see some tabs there, ask a question. So if you just press on that tab, you can type in any questions that you might have. We will endeavour to get through them all. If we can't, we might answer them offline tomorrow for you. There's also another tab there, book an appointment, if you want to book any appointment or see any of the people you've seen speaking tonight. You can register your club and you can download the exercises as well. So Luke will start his presentation first, and then I'll be back with some live Q&A with Luke. Thank you.
Hello, so my name is Luke Hart, and I'm going to present today on how to maintain strength, fitness, and a healthy lifestyle after competitive sport, but also after any injury as well. So this is applicable to lots of different situations that you might find yourself in. And so what I'm going to talk about is how being fit for sport is really being fit for life. If we're fit for sport, if we have the health, the fitness, and the strength for sport, and we can continue playing sport for as long as possible, then really that is the same as being fit for what we need for life and for health. And so when we look at the difference between elite athletes or a competitive athlete and those that have retired, it's very interesting to see that actually the bit that we've struggled to maintain after sport is actually the skill component of sports. So it's the agility, it's the speed, maybe the throwing or the specific qualities of when you're playing that sport that we lose. But what we can actually see in this study is that retired athletes and elite athletes actually have the same physical test numbers, even though they've been retired from the sport for a number of years. So what we see is that upper body strength and maximal strength in the upper body, as well as running tests, are the same in those who have retired as those in elite athletes. And that's really positive because they're the key areas for us, people who don't necessarily play sport anymore. They're the bits that we want to know about because they're the ones that are going to influence us, our health and our lifestyle. And we need to know what we need to do after sport, whether it's GAA, soccer, football, cricket, what we need to do to maintain a healthy lifestyle and maintain as much of our physical fitness as possible and how that relates back to our health. So the World Health Organization about 4 years ago changed their recommendations. So now they have a couple of different recommendations that didn't used to be there. So we still have the usual 150 minutes of light activity. But often we would already get this in our sports. When we leave sport, we probably need to find something that's going to replace this 150 minutes of light activity, 75 minutes of vigorous activity, and 2 strength sessions a week, along with minimizing our sedentary time. Now, sedentary time really is the big problem at the moment. With the COVID lockdowns, with people working from home, people have a much higher increased sedentary time than what they had even a year and a half, 2 years ago. But also this is a problem often after we finish playing sport. So usually if we're playing team-based sport, and in Ireland it's very, very popular with GAA up until our late 40s, we might be out of the house 6 hours during the week, 2-hour training sessions 3 times a week. And so when we stop playing, we're getting a huge increase in our sedentary time if we don't find something to replace that with. But also if we put work from home on top of that, then we're definitely looking at a bit of an issue, and we'll discuss that later. So what I would like to talk about today is 3 key areas: strength and power, cardiovascular fitness, and then we're going to touch on the role of BMI and body fat on your health, fitness, and wellness. So I'm going to start with strength and power. Now, the reason I'm going to start with strength and power is because this fundamentally underpins all the other qualities we're going to talk about, and I'm going to show you why. So when we look at strength, muscular strength is a big predictor of all-cause mortality. So a study done in 2 million men and women found that those who were stronger had significantly decreased risk of all-cause mortality, essentially decreased risk of death by any kind of disease. And so it was the biggest factor that played a role in reducing people's risk. And so what we want to know is how can we maintain our strength as we age, and why is that then important? So what we can see here is on the left, on the top side of the screen, we can see that a 60-year-old woman has the muscle mass there, and the black part or the darker part is the muscle mass. The whiter part is the fat mass. On the right-hand side, we have an 80-year-old woman, and again, we can see that dark mass being the muscle mass and the white being the fat mass. And what we want to do is we want to try and maintain as much of that darker mass as possible. And you can see on the graph underneath, we can see the slope of the line is the drop-off in the amount of muscle that people have as we age. And what we want to try and do is we want to try and minimize that drop as much as possible. So we want to try and get that line as flat as we can. And in some cases, even increasing. If you haven't done much strength training before or fitness work before, you might actually see an increasing line as we age. And the flatter we can get that line, the healthier and the lower our risk will be as we age. And so this doesn't have to be the case. We don't have to lose that muscle. What we can see here in a brilliant study done by Robolewski, who used MRI imaging to have a look at people's quality of muscle, they found that in a 40-year-old triathlete, they had a great muscle mass with very small amounts of fat mass. And if we compare that to a 74-year-old sedentary man, we can see that that fat mass has actually started to almost invade the muscle. You can see the white mass in between that darker mass, but also we can see that increased concentration of white mass around the muscle. And if we then compare that to a 70-year-old triathlete, we can see he almost has the same quality of muscle mass as the 40-year-old triathlete. And the best way for us to do this is through strength training. So whilst endurance training will also play a significant role, if we can keep strong and do some form of strength training throughout our lifetime, we can maintain that muscle mass. And so what's the best way of doing this? Well, we can see from this study here that looked at the difference in maximal isometric leg press and maximal bench press over a 21-week period, that the strength and endurance group that's circled there in blue had the best results. They had over a 20% increase in 21 weeks, which is absolutely fantastic. So while strength is important, it also shows that strength and endurance strength is important as well. And the combination of the two, like we're going to speak about tonight, is the way to get the best results possible for yourselves and for anybody after sport or returning back to exercise after an extended period away. And then I wanted to touch on why strength training is important for a lot of our conditions as well. So I think, as Mark spoke about earlier tonight, obviously ACLs are a key kind of risk in field-based sports. We see them a lot in GAA, soccer, rugby, and other sports as well. And so I'm sure many of you may have had maybe an operation on the knee, maybe had meniscal issues or ACL issues. And so what you really want to know is, okay, what can I best do to help prevent any further issues down the line for my knee? And what we found that in those with osteoarthritis, which can be a common complaint maybe after knee surgery or after having any knee issues down the line, is that the people who increased their strength had a 22.5% reduction in pain and had a 17.5% increase in their function when they already had knee osteoarthritis. And this will only be better if we start sooner. Also, we found for those who had improved quadricep strength, who already had knee osteoarthritis, found that if they improved their quadricep strength, they had significantly improved gait and movement patterns afterwards. So that then brings me on to how strong is strong enough, and what do you need to do, and how can you quickly and efficiently see whether you're strong or not? Well, this test looked at a leg extension versus a sit to stand. And there's a really good test that you guys can all do at home. So what you do is you take a seat where your knee lines up with your hip, so about 90-degree angle. So a kitchen chair will usually be perfect. And you have to see how many sit to stands you can complete, full sit to stand, so sit all the way down and stand all the way up in 30 seconds. And if you can achieve more than 11, then you're above that kind of poor side of things. So if we're below 11, that shows you need to do a little bit more work, okay? If we're around 15, we're around hitting the averages. And if we're doing 22, we're into a good position. And the younger we are, we might want to push that even a little bit further. So up to 27 is a really good result. If you get 27 plus, you're excellent. And so it's a really easy test to have a look to see where you're at. And we have other tests here at the clinic that we have in the fitness lab, where we test this in even more detail and also look at the differences between your left and right leg. Really important for those who have played kicking sports and field sports over a long period of time. So that's a really good test you can do at home. But what do we suggest here at the clinic? Well, for those of you that go to the gym, we would suggest that you try and achieve a front squat of about 0.5 to 0.75 times your body weight. So let's say you're an average of 80 kilo male. You want to be aiming for about 40 to 60 kilo front squat. And this is the same across gender. So female and male should have the exact same according to their body weight. A wall hold, if you don't like to go for the gym, is a really good substitute. And 4 times 1 minute is the minimum target you should aim for. And you want to try and maintain that for as long as possible. It's a fantastic exercise. And a leg press of 1.5 to 2 times body weight would be another good alternative as well. For our posterior chain, so the muscles at the back of the body, our lower back, our backside, and our hamstrings, a deadlift of 1 to 1.5 times body weight is brilliant. And a hip thrust of 1 to 1.5 times body weight equally is very good. And then lastly, for our upper body, which is really important for females because of osteopenia, osteoporosis, and we see a decrease in bone mineral density as we age, the upper body is really important. So 8 to 10 good quality push-ups would be absolutely fantastic for both males and females to aim for. Between 1 and 3 pull-ups would be a brilliant aim or a brilliant target, especially for most females. If you can get 1 to 3 pull-ups, that would be absolutely fantastic. And if you don't have access to a pull-up bar, then pulling something with 30 to 40% of your body weight, so a dumbbell row, a cable row, a band with lots of attention, that would be about 30 to 40% of your body weight single arm, would also be a brilliant aim to try and achieve, and would really try and minimize those effects of osteopenia and osteoporosis later in life. So now we're going to move on to aerobic fitness and physical activity and the role that they play in your health and fitness. So why are they so important? Well, VO2 max is something that we use to test your fitness. So we use it here in all of our health and fitness tests. So every health and fitness test at Sports Surgeon Clinic has a VO2 max because we see it as vital and most vital test to know your risk, but also how healthy you are. And a Finnish study that followed approximately 2,000 males with no history of cancer for 16 years found that if you have a VO2 max above 33.2, and a lot of people who have Garmins can get this number off their Garmin as well, it's not as accurate, but it's still a good proxy, resulted in a 27% less chance of getting cancer and a 37% less chance of dying from cancer. Those who done 2 hours of moderate exercise reduced cancer death risk by 26%, again, a big increase. And an improved VO2 max decreased the risk of lung, gastrointestinal, and prostate cancers. Moving on to dementia risk, which is a big topic at the moment, we find those with moderate to higher fitness have a massively decreased risk of dementia. And so we see for every 3.5 mils of oxygen, which is roughly about between 7 and 9% improvement for the average person in their fitness, they get a reduction of 14% in their dementia risk. And for those who already have a moderate to higher cardiovascular fitness, they have greater than a 50% reduction in the dementia mortality risk, so death by dementia. So there's a lot of significant health reductions that come from having a higher VO2 max and therefore a higher fitness level. Lastly, and this is the one that we most know about, is that if we have an increased fitness, we have a reduced risk of cardiovascular disease. So if we have a moderate to high fitness, we have a 53% reduction in the risk of cardiovascular event or heart failure, and an increase of just 9% in our VO2 max decreases the risk of, or decreases our levels in our blood pressure and our cholesterol, 2 key markers. So if you do have issues with blood pressure and cholesterol, getting fitter will significantly help alleviate those. And so we know that we need to change it. So how do we go about doing that? We want to improve our fitness. So how are we going to do it? Well, the first rule that I have is take care of the basics. So this is the first step that we take with our patients. And what I mean by that is take care of your daily steps. So what we can see from here is that anything after 6,600 are roughly around about 7,000 steps. There's a big risk reduction. So we can see that line drop significantly between 1,600 and 6,600. But after that, it starts to level off. And what this study showed was every 1,000 increase in steps per day had a decrease of 23% on your mortality risk, essentially your risk of dying. So getting over 7,000 steps every day has to be your first priority. So if you're someone who's finished sport, or maybe has had an injury, or has had a very stressful job over the last year and therefore has dropped away from maybe being as physically as active when sports shut down, they kind of dropped off. Well, getting your steps in is the first kind of port of call, and getting over 7,000 will be the main aim, really. Number two is just to start, and start now. And better yet, it probably would have been better if you started yesterday. So what we see is that people who do lifelong exercise have a significantly improved kind of status in older age. And that those who do some form of exercise, whether it's hard or easy, get the benefits over the long term. So someone who does lots of very intense exercise for maybe only 10 years, but then drops off, probably doesn't have the same health advantages as someone who does a moderate or even low amount of exercise, but over a long amount of time. And what we can see here on this study is that red line is the line of independence versus dependence in older age. And what we can see is that this white cohort in the white circles, they're the people that have done lifelong exercise and purposeful lifelong exercise. We then see the people in the gray, those that have done lifelong exercise and just at a moderate level. And then those that are in the black dots are the older but still very healthy people, okay? And what we can see that even when you're old and healthy, you're only just above that independence-dependence line. However, if you've done lifelong exercise, you can see how you are way above that line. And there's a much bigger gap between independence and dependence. Now, this is really important because as we live for longer, we want to be able to do what we love for longer as well. And what we don't want to be living longer, but being dependent on other people. And a great way to try and prevent that is to make sure we're doing some lifelong exercise, starting from our 20s and 30s, or even 40s or 50s, and then continuing that all the way through. And it can make a massive impact to the life that we can lead when we're 70 or 80. So rule number 3, and the final rule, is intensity over duration. Now, if you do run 10Ks, if you do like to do marathon training, I absolutely would not stop. But there are some very interesting findings. So what we've found, or what previous studies have found, is that if you do some high intensity training, even just 60 seconds work with 75 seconds rest 10 times, and you do that 3 times a week, in 5 weeks, you can have a 10% improvement in your VO2 max. Now, we saw before that a 9% improvement significantly reduces your cardiovascular disease risk, significantly reduces your dementia risk, just by 10% improvement. And you can get that 10% improvement in just 5 weeks by doing some high intensity interval work that will only take you the guts of 20 minutes to do. So it really shows you how easy it can be if we continuously do it over a steady period. And then secondly, what was found was that increased rating of perceived pleasure was higher in high intensity training than in continuous training. Now that's really important because if we want to make this a habit and we want to do it for the long term, we need to make it efficient and we need to make it enjoyable. And what they found was that even though people worked harder doing the high intensity training, it was much more enjoyable for them. So shorter amounts of exercise, but with higher intensity, seemingly give us the same, if not improved results over continuous training. However, continuous training does have lots of benefits and lots of mindful benefits as well. So it's not that we're saying if you're doing continuous training, you should stop and change, but you might think about adding in some high intensity training into your training program as well. So then finally, we're going to move on to body mass index and body fat percentage and the role that it plays in your health and fitness. This is the one that's spoken about in the newspapers the most and is all over social media as well. And there's some interesting findings. So we do find that in the studies that obviously those with a higher BMI and higher body fat percentage do have a slightly higher or significantly higher risk of all-cause mortality. And we do see that in some of the cancer risks, it does go up when our weight increases and our BMI goes up. However, these are big studies taken across wide selections of the population. And so there are some other factors that we need to account for. Just before we move on from that though, what I would like to talk about, and specifically because Mark was talking about ACLs before us, is that those with osteoarthritis, which can be slightly higher risk if we've had a knee operation, if we've had meniscal pathology, or we've had an anterior cruciate ligament injury, we do find that body mass is really important for those people. Okay, so what we find is that if you have osteoarthritis or if you have had significant surgeries to your knee, it might be a good idea for you to try and maintain a fairly lean body mass, because what we do see is for every 1 kilo you're over what your body mass should be, we see a 4 kilo increase in the compressive load in your knee. So for every 1 kilo you lose 4 kilos of compressive load on your knee, okay? And for those who lose on average about 5 kilos, we see a 50% reduction in their osteoarthritis risk. And even if you just lose 10% of your body mass, there's an 28% reduction or improvement in function. So coming back to BMI and body fat, well, it's a bit of a red light moment, okay? So whilst the social media and the newspapers say that, BMI is the be all and end all, it really isn't. Recent studies have found that actually people who are powerful and who are strong exhibited a reduced 9-year difference in their life expectancy. And that was including BMI, waist circumference, and body fat percentage. And what they found, they split people into 4 groups, and they had powerful but overweight, powerful and lean, and then they had lean and weak and overweight and weak. And what they found was actually the people who were powerful had much lower risk than the people who were weak. So if you were overweight and powerful, you had a significantly decreased risk versus those who were weak and lean. So actually being powerful and being strong, but maybe being slightly overweight, was not as bad as if you were weak and lean. And so it really does kind of go against just using BMI or just using body fat percentage to tell us how healthy you are. It is significantly more important for you to be strong and fit, but slightly overweight, than being lean and maybe trim, but not strong and not cardiovascularly fit. And I think that's a really important message that gets missed in the current public information that's out there. So it's really important for you to be strong and cardiovascularly fit, but a little bit overweight. You're in a much better place health-wise. So that brings us on to then, what should we be targeting and what do we want to do? Well, shock horror, the World Health Organization is pretty much bang on the money. So if we can do 150 minutes of low intensity exercise to try and replace maybe those couple of hours that we've missed during the week due to sport, golf is a brilliant example of where you can get 4 hours of low intensity exercise straight away. If we can include some vigorous and moderate exercise every single week, so that high intensity training that we spoke about, 1 to 2 sessions of that a week, if we're getting our low intensity exercise, would be great. And if we're not getting our low intensity exercise, maybe 3 sessions of that a week, maybe at the end of your gym session for 10 to 20 minutes would be a brilliant way to bring that in. 2 strength sessions a week is absolutely vital. Remember, strength underpins everything. So strength allows us to keep doing what we love for longer. So that's going to keep us playing golf into our older age. That might keep us on the 5-a-side court for another 10, 15 years. So it's really important you stay strong, because that's the one key area that underpins everything else. If we're strong, we don't get as many injuries. If we don't get as many injuries, then we can carry on doing what we love and the physical activity that we love. A little bit of balanced mobility, including a good quality diet. So 80% of the time doing the things that you know you should do, taking the right decision, so that 20% of the time you can have the glass of wine and maybe the pizza on the weekend that you want. But if 80% of the time we're doing the right things, that allows us to have that 20% of the time where we're maybe not doing quite the right thing. And then getting those 7,000 steps a day. We saw that massive drop off after 6,600 steps in our risk. So if we can get 7,000 steps every day, especially if we're working from home, that's probably the most important. If we're working from home, 7,000 steps is actually quite a task, and we really need to focus in and get that. Then that's brilliant. Now, for all the things we've spoken about tonight, we offer a fitness health lab here that is covered by both VHI, Irish Life, and Leia. So please have a look in your policy, because we can do all of the testing and give you all the information that we've spoken about tonight in a report and give you personalized suggestions and personalized programs to help you with that. Alternatively, VO2 max testing is the absolute vital test that we would suggest for everybody. It gives us a brilliant window into where your health and fitness is. And we can conduct them on site here in the Sports Surgery Clinic. So if you're interested, please let us know at fitnesslabs@sportssurgeryclinic.com, or give us a ring on 01 526 2050. And we'll get back and give you some information regarding the VO2 max, which can really give us a great insight into where your fitness is at currently and your risk going forward as well. Thank you very much for your time. And if you have any questions, I'll be more than happy to take them after this. Thank you.
Thanks, Luke. We'll all be doing our 7,000 steps now after watching that. So the first question is from Con. He said, I only have a limited time to train. Should I prioritize strength or some form of cardio?
So I think, as you kind of saw in the talk there, I think strength really underpins everything that we do.
Yeah.
So if we can stay strong, it allows us to do all the things that we really love to do, whether, that's playing 5-a-side football, golf, tennis. So strength is definitely a key quality. So I think probably some part of the week should be dedicated to strength, but we only really need at least 1 session a week to really stay strong. So the rest of the week can kind of be prioritized to maybe a bit more cardiovascular. So I think we definitely need to have some strength in there, because if we don't use it, we lose it. But probably cardiovascular is also very important. So probably a 60-40 split is a really good way to kind of go about it. But it also comes down to what you enjoy and what you love as well. So if my time was limited, I would probably look to do 1 strength session a week and maybe 1 to 2 cardiovascular sessions a week. And that's a really nice split then.
Lovely, thank you. This is a question from Mia. How long after a knee scope and SSC would I expect to be able to play sport easily again? And will the pain go away following the strength and conditioning program?
Really good question. So I think this depends on what you have done. So not every knee scope is the exact same. Yeah. So I would tend to say you probably want to get back to full sport and competitive sport. You might be looking up to 3 months, depending on what you've had done. You can definitely get back to certain activities quicker than others. So it does depend on what sport you play. So if it's a multi-directional kind of court sport like tennis or field sport, you might be looking at slightly longer. Whereas if it's more linear based, such as running, it might be a little bit quicker. And strength and conditioning is going to play a huge role in that, because we know that after the operation, you'll probably lose maybe 10 or 20% of your strength quite quickly. Whereas if you introduce a strength and conditioning program early, we can get that back much quicker as well. So it definitely depends. I would say I'm being more cautious on that kind of 2 to 3 months side. It might be a little bit quicker than that, but to get back to full field sports, you might be looking at the 3 month kind of stage.
Okay, thank you. Owen O'Neill, what pace of running is needed over the 60 seconds?
So I think it's individualized to everyone. So what I would say is over the 60 seconds, you want to be working quite hard. So we use a concept called rating of perceived exertion. So how hard you work. And you can quite easily track it from 10 being like what pre-season would be like really, really hard. And 1 being pretty much you just getting out of bed in the morning. And if you can kind of be around a 6 or a 7 for that 60 seconds, so you're working about 7 out of 10, then you should be getting all the benefits. If it's a little bit too easy, then you might miss a few of the benefits, but there's absolutely no need to push it to 10 or 9 or 10. So that kind of moderate to high intensity is a kind of good level. And in terms of speed, it really is individualized.
Okay. Can you overdo your sessions in a week?
Yes. So the analogy of we're a cup and we can only fit so much water in the cup is definitely true.
Yeah.
So if we do too many sessions in a week and don't provide enough recovery, then that is when we can kind of get overtrained, we can experience burnout, or we get a soft tissue injury. So recovery is really important. It's probably one of the things that we see least programmed into people's kind of training. When we train, we're actually breaking down muscles. When we recover is when they get stronger, better. And that's the same for cardiovascular fitness as well. So it's really important that when we train, we give adequate rest so that we can actually improve and get better, because that's when the kind of magic happens, really. So we tend to say at least 2 rest days in a week, ideally, where you're not doing too much at all to allow you to recover. And that does depend on people's training history as well. Some people might be used to training a little bit more, in which case they can handle that, whereas other people, you'd want at least 2 dedicated rest days in a week.
Okay, good, thank you. Sergey, do you recommend protein shakes for recovery, best diet for recovery?
Yeah, so protein shakes can be very handy and they're readily available quite easily. So that's good. I would really just see them to supplement your nutrition though. So you can't really use them to replace good nutrition, but they are very handy to supplement what you do and to have them on hand. So immediately after or within half an hour after a training session is a really good window to take in protein. So protein shakes, I would definitely recommend them if you want to utilize them. But having said that, the evidence is there that chocolate milk or a high protein chocolate milk like Avamore that you can buy off the shelves is just as good in some cases for most people. So it doesn't have to be used, absolutely, but it can be something that can be definitely advantageous to use.
Okay, thank you. Etna said, should I be doing weights 50 plus? I think that means when she's over 50.
Yeah, absolutely. Actually, that's probably the time where it's most important. There's some brilliant benefits to bone mineral density, to tendon and tendon health. For anyone who's experienced osteoporosis or osteopenia, we see brilliant benefits. So there's absolutely no contraindications to doing weights over 50. The only thing is you just see really good benefits. Okay. Obviously, an individualized program would be important if it's something you haven't done before, but there's absolutely no contraindications to doing it over 50. Okay.
Lisa McDaniel, she's just talked about her son there. He had a large osteochondral defect in his knee. Get it fixed. He's 11 days post-surgery, nearly 5 weeks since the initial injury when he was put in a full brace. She's just concerned that he's a significant amount of muscle wastage. How can he prevent this?
So I suppose post-surgery, it's very hard to prevent because post-surgery, you are going to get a certain amount of muscle wastage. The most important thing is to try and get that muscle, that thigh muscle, the quadriceps back or activated as quickly as possible to minimize that atrophy. So there will always be some, but by doing some exercises, especially ones which are specific to the surgery and the injury, then we can maximize the amount of muscle mass we can retain. And that's really, really important, that those early stage exercises are all there to maintain muscle mass and trying to get that joint moving as free as possible as well. So I think if they can do some exercises which really encourage that muscle to activate and stay, then I think they'll be in a brilliant position. But some, you will have some atrophy. So it's just trying to maintain as much as possible with exercise and try and kind of stop the atrophy as best as you can.
Yeah. Holly's asking, do all health insurances cover the fitness lab testing, and how would she apply?
So it's all on certain policies. So Leia, Irish Life and VHI all cover the fitness lab, but it depends on what policy you're on. So the best way to go about it is to check your policy and check your pack. Usually the benefits like the fitness lab are down towards the end of the policy. But if you're unsure, you can contact us here at the fitness lab at Surgery Clinic, and we can check the policy that you have and see whether it's a benefit you have. Or you can ring your health insurer and see as well if it's a policy that you have on your plan. And that's probably the best way, because lots of people have it in their plan, but they just don't see it because it's right down the bottom. So if you check your plan or your documents, you should be able to see if it's there.
Great, thank you. Derry O'Toole, what is the best level of fitness you've seen people who've had knee replacements? I'm 52 and having a replacement on the 11th of December.
We see people get back to some really high level kind of activities. We've seen people get back to golf in really quick times. We've also seen people get back to quite dynamic activities as well. Obviously, initially, your non-impact activities are going to be the ones that you get back to. And there's no limit really to the level of fitness you can get back to, because obviously something like cycling, you become very, very fit, but actually puts very little impact on your knee. So we've seen some very fit people come through, and I think really you're only limited by your ambitions. There will be some activities that you might find a little bit trickier to do, especially initially, but really there shouldn't be any limit. So however fit you are now pre-surgery, you should at least be able to get back to that post-surgery, if not a little bit better again. So there's definitely no limits that you should be placing on yourself after knee surgery.
Right, I think this will be the last one. Sunita, would you recommend a 45-minute Pilates class as a strengthening method, or is that more balanced conditioning?
Yeah, great question. I think it does depend on the Pilates class that you do. But generally what we would say, especially to see the benefits in bone mineral density, we want to really see something that's over and above our body weight. So whilst Pilates is definitely a good workout and very, very good for your health, it's probably not quite taxing enough or has enough resistance to necessarily influence, say, bone mineral density and other areas. So I think it's a very good workout, but definitely something a little bit above that. And you would only need something to supplement it. So it might only be 2 or 3 exercises to supplement what you do in Pilates, would then give you all of the benefits, whereas Pilates alone might just not be enough to really stimulate the muscles and the bone mineral density side of things quite enough. So that would be the only thing. And it depends on the class. You can get some quite more relaxing based Pilates classes and some which are very, very hard. So it just depends on your class and on your instructor as well.
Luke, thanks very much for joining us tonight. So we have our next speaker now is Tommy Mooney, and Tommy's one of our strength and conditioning coaches here as well, and Tommy will join us afterwards. So just, you can still ask questions there, and like I said, we will try and answer all of them tonight, and if not, we'll send them out to the speakers and they can answer them for us. Thank you.
Hello, and thank you for taking time out of your evening to tune into our SSC webinar series this evening. I'm Tommy Mooney, a senior S&C coach at the clinic here. Alongside my role here at the clinic, I work with a host of different athletes and different ages from a multitude of different sports, including team sports, individual sports, field sports, court sports, track and field, ranging in ages from 6 years old to 80 years young. Okay. My presentation today is going to be about how we can protect our young athletes in modern sport. I'm going to suggest a 3-pronged model for optimum health and development. First and foremost, we're going to talk about the importance of the multi-sport and using multiple different sports and activities to try and enhance our movement vocabulary. By movement vocabulary, I mean trying to think of the more words you have, the more sentences you can make. So the more movements we learn, the more skills we can accomplish and showcase in our sport. We're going to talk about training loads and trying to find the optimal balance between rest and training. And then thirdly, we'll talk about strength and conditioning and utilizing things like resistance training to again enhance that movement vocabulary, increase our robustness, improve performance, and reduce the risk of injury. Okay. First, I'd like to present a story to you. So we have two kids here, both 7 years, 8 years old, so old enough to know that they know everything. Jack here on the right-hand side is a tennis player, adamant that he wants to become the next big thing in tennis. His parents are certain that he's going to become a tennis player, and his whole life revolves around playing tennis, training tennis, and getting as good at tennis as possible. Okay. Jill here on the left-hand side plays a multitude of sports, gymnastics, tennis, GAA, and athletics, outside of her busy social schedule. And she wants to become a gymnast or an influencer when she's older. So my question to you is, which person or which child do you think has a longer and more successful sporting career? Now, ultimately, we can't pick one and we never know. There's been many childhood prodigies like Tiger Woods, Lionel Messi, the Williams sisters, who've gone on to emulate their childhood success. But despite that, we would suggest that adopting a multitude of sports and playing many different sports is typically the optimum way to try and develop a broad range of skills and capacities that can then lead into your final sport or your sport at the end of your career or as you age. Okay. Other benefits of multiple sports are that children are going to learn multiple different skills. It's going to help prevent burnout and increase participation for longer, and reduce the risk of injury, improve cognitive skills and decision making, typically more enjoyable as it offers some breaks in between different sports. And also we know that early sport diversification is linked to a longer sporting career, as we already mentioned. Okay. Forgetting about sport for a minute, we know that children nowadays are typically slower when compared to children 30 years ago. They are weaker when compared. They are less physically literate and less physically active. Okay, so introducing children who may not be playing sport to physical activities like our strength and conditioning is going to be really important. We also know that less than 5 hours a week of physical activity can increase the risk of injury. Obviously, there's a bell-shaped curve here that we know if we do too much training, that can also be a risk factor. But I think this became quite evident off the back of COVID, where we saw an extended period of not training, followed by a spike or an increase then in our training load. And this is something that we've associated with an increased risk of injury. Okay. We spoke about strength and conditioning. So what is strength and conditioning? The bottom left here, we have an example of what it doesn't look like. So obviously, too heavy, too young. A bit of tongue-in-cheek photo there. And moving on, though, we have examples of multiple different movements: crawling, jumping, landing, running, moving, lifting, squatting, in an environment that is safe, fun, cohesive, but also challenging. So we have conditions here that make the exercise task a little bit more challenging, or the constraints a little bit more challenging. And as they progress and get older, then we move up to maybe loading those exercises or those patterns to still continue to increase the challenge or difficulty. Obviously, there are certain concerns and or misconceptions around strength and conditioning. It's important to note that strength and conditioning isn't just gym-based and strength-based. Speed and agility and muscular endurance can be enhanced by this, although we won't talk too much about these particular components today. And we already mentioned that the improvements it can have in our physical literacy, our skills, balance, and flexibility. As mentioned, one of the concerns typically is around it being dangerous, but it's important to note that sport in general is equally, if not more, dangerous. Okay, this is an example of such. So we know that sport in itself is inherently dangerous. So the better we can condition and prepare our young athletes for this, the safer they may be when they do take the field. Okay, some other common misconceptions are around stunting growth. This stems from anecdotal data that elite weightlifters are small and stocky, therefore weightlifting must stunt their growth. This is akin to saying playing basketball will make me taller because all elite basketballers are tall, therefore playing basketball will help increase my height, which obviously isn't the case. We spoke about the dangers. Other misconceptions can be that it will make you slower, done properly. Proper strength and conditioning should help increase speed rather than slow us down. Building big muscles, again, this is highly unlikely in youth athletes, as we don't have the hormonal profile that's going to allow for this, and typically takes years of training to do so. And growth plate injuries. Your epiphyseal growth plate injuries that were once of concern has largely been disproven and is more likely to occur in jumping and landing and our field sports as opposed to our gym-based sports. Right? There's been a host of research to back this up and evidence to back this up, that weight training in youth is safe, that long-term responses to it are positive, and then position statements from the UK and US Strength and Conditioning Association from some of the lead authors in this area, in particular Rodri Lloyd, Dr. Avery Feigenbaum, John Oliver, to name but a few. Okay, so this table here shows the incidence of injury in some youth sports. Okay, so looking at some popular field sports like rugby league, soccer, and GAA, and looking at the incidence of injury over 100 hours of match play. What we can see here is that the incidence of injury in these field sports is considerably greater than our weightlifting activity. By weightlifting, we're referring to the sport of Olympic weightlifting. You'll see two studies here in particular. Boys and girls as young as 7 had a 0 incidence of injury over 1 and 2 years. And this study here, where there was 1 injury, happened with a weight plate falling on the foot. So not even the sport itself, but rather from maybe not paying attention during the down period within the activity. Okay, again, emphasizing the safety of these when done properly. Okay. The injuries in these activities are typically as a result of poor technique, excessive loading, as we've shown in that picture earlier, training whilst fatigued, perhaps maybe not paying attention then, and a lack of qualified supervision. This is an important point to note, that we need to make sure that the people who are supervising and running these sessions are qualified. I'm sure there's a host of coaches and parents on the call here who work with these young age grades and know how difficult it can be to keep them engaged and supervised. So I have a lot of respect for anyone working with these young athletes and young groups, but it is important that whoever is leading these strength and conditioning sessions is appropriately qualified. Okay, the benefits then of strength and conditioning can help increase our strength and power, bone strength and density, balance and coordination, speed and agility, reduce injury risk, enhance our sports performance, and our outlook on physical activity. This is particularly important maybe for people who don't play sport, and offers another avenue for exercise to encourage and engage with exercise and physical activity without necessarily partaking in a main sport. Okay, this again is another example of the time loss injuries in an elite soccer academy. This is Arsenal. Prior to 2013 and Des Ryan and his team taking over, they had quite a high incidence of injuries. After 2013, when they implemented a world-class strength and conditioning program, they significantly reduced the number of injuries over the next couple of seasons. Okay, obviously we can't completely eradicate injuries, as we already mentioned. Sport in itself is injurious and particularly risky, but we can do with good strength and conditioning, we can decrease those numbers. They actually published a paper on this for anyone that is interested, showing their pathway, working with functional competency first and progressing up through different phases, some key considerations throughout developing a soccer academy S&C program. Okay. When can we start? How young is too young? This study by Rodri Lloyd and Feigenbaum, who we mentioned earlier, showcased that those who started during pre-adolescence achieved a greater level of motor capacity in adulthood relative to those who started during adolescence, relative to those who only practiced sport, and relative to those who did no sport or conditioning. So again, showcasing the earlier we start, the higher the ceiling we can achieve. Okay. Again, this is a youth physical development model from Rodri Lloyd and John Oliver. Again, showcasing the subtle differences between male and female, but also emphasizing some key areas. So anything in bold is something that should or could be emphasized during that age grade. So initially we're thinking functional movement or basic functional movement. As we progress on and get older, we're thinking more sport specific skills. Training initially will start with very low or unstructured and fun, progressing into more structure and more high-end control instruction. Okay, it's worth noting that there are some subtle differences here. We know that females mature earlier than boys, although some boys may not fully mature ever. If anyone is looking to read into this a little bit more, there's an excellent book by the two authors, and then the paper here around that is shown here. This is an example of a long-term athletic development model specifically for weightlifting. Okay, so what we see here again, it's quite low structure to start. These are some suggested ages here. They're not necessarily prescriptive. Obviously, anyone who does start, irrespective of what age they start, is going to start in stage 1 and gradually build up. A 12-year-old, though, may progress a little bit quicker than a 6-year-old, for example. Stage 1 encompasses fundamental moving or weightlifting skills with a focus on physical literacy. As we progress here, again, still staying quite low structured, quite fun, quite engaging, with still a competent or focus on technical competencies. And as we progress on then after a number of years of training, we can still focus on our technical reinforcement whilst adding a little bit more load or more performance-based outcomes, and then finally progressing into performance or elite level, whereby we're focusing now more on performance and load. Okay. Again, just to go through these stages in a little bit more detail, stages 1 and 2 are going to be largely based around bodyweight training and mastering the basic exercises and movement patterns, progressing into maybe some soft resistance, things like med balls, sandbags, and then finally progressing into your barbell training. This is similar for our power progressions. Important to note that strength underpins power, although both are important. Utilizing some power exercises can help ensure that we get the maximal transfer across from our strength training. Okay, again, similarly here, we're interested in jumps, hops, throws, and gradually introducing maybe some light resistances before we consider moving on to more weighted or loaded progression. Okay, so when do we progress from body weight to barbell training? When we have good control over our own body and limbs, good positions and patterns in the 6 major movements. Okay, so for example, 6 of those movements might look like this. So this is an example from a youth scoring table. So when you can achieve 18 points in each of the exercise categories, that's a sign that you've mastered or you're competent with your own body weight and are ready to progress on to loaded variation. Okay, so for example, here we get points relative to the number of repetitions we do. Points add up over the different tests, and that allows us to achieve our 18 points plus. Again, those scores may be a little bit different for our male youth athletes. Okay, if we wanted to then put that together in more of a template for programming, again, in our beginner or young phases, we're starting with fundamental movement. We're starting with body weight, so less intensity and less frequency, maybe 1 to 2 sessions a week. As we progress, we might increase the amount of sessions or increase the intensity, whilst reducing the volume. Okay, and that continues to progress on as we get older and more competent. Speeds increase, intensities increase, number of sessions may increase, and the rest time will then also have to increase to accommodate that. Okay, so advice in summary for our parents: I would encourage everyone to try and get their children to engage in PE. That way they're going to see a multitude of different sports and skills, to get out and play with their friends as best or as much as possible, to incorporate at least 1 rest day a week where we're completely away from structured sport, to try and play different sports in the off season, and particularly when the down season is there. That gives us an ideal opportunity to sample other sports, and communicate across sports. So if we are playing a multitude of sports, to make sure that you as the parent are communicating that across the coaches. Obviously, our soccer coach won't necessarily know what we did with our GAA team. So it is important that someone acts as a go-between to liaise across the different sports and coaches. Try and reduce training load during growth spurts. So we know if there is a heightened or a rapid spike in growth, that can act as a predictor for injury. So it is important during those periods that we reduce the training load, particularly the on-field training load, and that might be an opportunity where we can focus more on the strength and conditioning elements that we spoke about. Trying to introduce resistance training or strength and conditioning under qualified supervision, and to make sure that we have fun. Again, the more engaging and enjoyable we can make this, the longer we'll participate and the more benefits we'll see long term. Thank you very much for listening. If you'd like to reach out via social media or have any questions, I'd be happy to answer them. Thank you.
Thanks, Tommy. It's a really interesting talk. So we're going to start off with the first question from Peter. At what age would you think elite level young GAA players should be asked to choose between sports?
Yeah, it's a great question. Ultimately, it's hard to say definitively. Like you need to consider the individual case. How many sports are we talking about? Do the two sports cross over? Are they quite different? In reality, if we're talking about, I think I mentioned Gaelic football there, did it? You're probably thinking after minor, so that kind of under 18 age when you're really starting to get into the nuts and bolts of the sport, and you want to start to specialize in order to, I suppose, advance as much as possible. Obviously, there are outliers, and there's people that have gone further than that and gone longer than that. But as a general rule of thumb, give or take about 18 years old is when you're going to start to specialize to try and, I suppose, develop as best as you can in that particular sport and dedicate as much time to it to optimize your performance, but also then to, I suppose, to ensure that you're not doing too much and too many other bits. But obviously there are outliers along with that as well. Okay, thank you.
Question from Sergey. Do you have any strength and conditioning plans that you would share for teenagers?
Yeah, absolutely. I suppose we kind of briefly spoke about that and mentioned some ideas in the talk itself. We spoke about the importance of, I suppose, seeking professional guidance. And that's where maybe touching base with a local S&C or coming into the clinic is going to be beneficial there, rather than kind of a generic program. You want probably something a little bit more specific and tailored to the individual, to their training needs, to their sport, and then to the injury history if there is one as well. So I'd be reluctant to go something too generic, but at the same time trying to reach out maybe to people around you and or coming into the clinic perhaps to get something put in place.
Okay, thank you. Now, there's a question here, and we were just talking about it. It's from TY. He was asking about when players are in small to medium schools, and I imagine it means that they're playing a lot of sport in one school and a lot of teams. How can you monitor them to avoid them overtraining and burnout or injury?
Yeah, that's a tough one. Like if there's a small club or a small school, I suppose the talent pool is inherently going to be smaller. Therefore, the same people have to play for multiple teams, perhaps multiple age grades, multiple sports. That can be challenging. I suppose the most important thing is the player and I suppose the parent and coach's relationship and trying to make those communication channels as open as possible so that there is a link between everyone and monitoring that. So I would say first and foremost, communication is the most important thing. And then just, I suppose, asking the athlete, how do you feel? During periods of a growth spurt, that's when you might kind of try and reel in the training a little bit and reduce the training load a little bit. Maybe that's where you could focus a little bit more on strength and conditioning activities or not as much heavy load on the pitch. There are other things you can do in terms of, I suppose, monitoring training in terms of maybe the minutes on the pitch or how much training hours you're doing a week as a slightly easier tool to monitor, and just making sure that that's not peaking or spiking in certain points of the year and stays a little bit more consistent, but also then having periods within the year and within the week, within the month even, where there's going to be slightly lower periods as well to facilitate rest.
Okay, thank you. Question here from Petra. Now, this is more of a general question about how much pain should be tolerated after running. Normally it gets better after 2 to 3 weeks of doing moderate exercise. Is it better to continue running, or is it better to do light exercise and then try and go running again after 2 to 3 weeks?
Yeah, well, I suppose first and foremost, you have to consider, why is your knee sore? Yeah. Ideally, you're not ever really exercising and or running through pain. Pain can act as an inhibitor. It can, lead to obviously more pain or perhaps worsening of the injury or the underlying injury. So ideally trying to get to the bottom of why the knee is sore and then rehab that and get back to running pain-free. So I'd be reluctant to encourage anyone to run through pain at any kind of age or level, really. So try and get to the underlying cause, see a physio or someone and try and get on top of it that way. If you can find other modes of exercise in that period that are pain-free, maybe less loading or less weight-bearing activities, absolutely work away with them. But I would still advise to try and get to the underlying cause of it and rehab that and get it better before really pushing on the exercise or training through pain.
Yeah, thanks, Tommy. This is the last question now from Paul Wallace. He's how can a 17-year-old plan for post-surgery for a ruptured ACL operation due this month? What strength and conditioning could be done during rehab?
Okay, sorry, say that one again.
So he said it's a 17-year-old. He's having an ACL. He's got a ruptured ACL, and I think they're asking what strength and conditioning should they be planning to do afterwards. But I'd imagine that as well be under the consultant as well. Yeah. So the consultant is going to have some clear guidelines. I guess it depends on what stage you're at. Further down the track, you're going to be able to do a lot more. In the early stages post-op, you're probably not going to be doing as much, but depending on where they're taking the graft from, whether it's the patella tendon graft or a hamstring graft, that's also going to influence it. But in reality, we want to try and keep the knee as calm and happy as possible. So not doing any activities that aggravate the knee, and then trying to build up strength in the localized area, the quad, the hamstring, the glutes. Again, that might be a bit more dependent on the graft type, but trying to build them up in pain-free movement. Initially, that might be a little bit more isolated, leg raises, etc. And then that progresses into more your generic kind of strength activities, like your squats, your single leg squats, etc. He said he's post-op though, didn't he? I think he's having surgery in 2 weeks' time. So he was
yeah. So pre-op, I suppose the goal is to again go in with the knee happy. So there's it's minimal effusion or swelling in the knee, full range of motion. Do what bits of strength training you can, provided depending on how tolerable the knee is to it. Typically at this point, if he's 2 weeks pre-op, usually the knee is in a pretty good place and you can actually do quite a bit of loading on it. Then post-op, obviously that's going to reduce again because there's going to be some swelling and inflammation and stuff. So usually the 2 weeks post, you can do a good bit of work. The key thing is, again, not to aggravate the knee in the process. So try and build strength as best you can. Again, specifically around the kind of quad is going to be the big one there, without annoying the knee in the process being a key factor there as well.
Lovely. Tommy, thanks very much for joining us tonight. And now our next speaker tonight is Mr. Mark Jackson, who's one of our knee specialists here at SSC. And Mark will be joining us after his talk. Thank you.
Hi, good evening. My name is Mark Jackson. I'm just going to talk this evening on the anterior cruciate ligament injury and a brief overview really of the reconstruction that we as surgeons often tend to offer. So just as a way of an introduction, my name is Mark Jackson. I'm a consultant orthopaedic surgeon based here predominantly in the sports surgery clinic in Santry, and I'm solely really now a knee specialist. So I get to see patients with their injuries and problems really from the ages of 12 and upwards, and patients come from pretty much the whole country and are referred in from their general practitioners, their physiotherapists, sports therapists, other surgeons, A&E departments, and other sources too. So my work is split. 50% of the work I do is predominantly sports and what we call soft tissue injuries, which incorporates the anterior cruciate ligament injury. So the top three pictures here are with a camera in the knee, and that's just looking at cartilage type problems. The bottom right picture and middle picture here are actually a cruciate ligament tear. So this is a torn cruciate ligament with my probe on it. And this is after we've cleaned it out and put a new cruciate ligament in place. And the bottom left picture is a more complicated reconstruction of many ligaments in the knee, such that sometimes we rarely, unfortunately, we sometimes see with knee dislocations. Then the other half of the work is more degenerative in nature, which means osteoarthritis. And that can involve offering patients procedures such as half or partial knee replacements, a full knee replacement, such as in the bottom left, more complex revision or complex primary total knee replacement, as on the bottom right picture, and other procedures such as this operation called an osteotomy. So today, with the coverage of anterior cruciate ligament injury, this is actually a very, very big topic. It's heavily researched over decades and still, I guess, incompletely understood. But we are getting better at what we're able to offer people with this injury. I'll try to keep it simple and not too surgical. We'll just go through some of the main points, such as what is the anterior cruciate ligament, how is it injured in most individuals, what options are we able to offer and discuss with our patients, and also talk about some of the consequences of this injury. So what is the ACL, or anterior cruciate ligament? Well, as you can see on this schematic picture on the right-hand side, this is looking at a right knee from the front, and the anterior cruciate ligament here spans the joint in the middle. So there are actually two cruciate ligaments, cruciate meaning crossing. So the posterior or PCL ligament is tucked in behind, with the ACL here in the front. The other two ligaments are the ones around the sides that we call the collateral ligaments. So the medial, or on this picture, it's called the tibial collateral ligament, or what we often call the NCL, and on the outside, the LCL. And these pictures, which are from cadaveric specimens, the right-hand picture will be looking at the front-on view of a flexed left knee, so the femur being the thigh bone. Here in the middle of the knee, we can see these two ligaments, and this is the ACL, joining the two bones, as we said, together. In most individuals, this will be in the region of about 3 centimeters long, perhaps about 8, 10, 11 millimeters in diameter. And it is shaped a bit like a ribbon. And this picture on the left shows that nicely, again, coming across the joint from the tibia, or the shin bone below, across to attach in a pretty broad way on the back of the thigh bone, the femur. And this is now a side view of the knee, with essentially the joint cut in half. So what does it actually do? Well, it is an important primary stabilizer of the knee, and that's the role of a ligament. It's to stabilize the joint. A good way to think of it is as a guardian of other structures too in the joint, and in particular, the important meniscal cartilages, which are the big cushions and shock absorbers inside the joint. And in rotation, it becomes particularly important, such as you might see Lionel Messi doing in a typical pivot and turn maneuver. And if it's torn, it means you've now got an ACL deficient knee, and that individual will often lack confidence in these kind of movements. So it's a fairly small ligament with a big job to do. And in humans, it hasn't necessarily really evolved for the demands that we put it through. So if you compare our cruciate ligament to an animal such as a mountain goat, you'll find that actually the mountain goat has a far better, bigger, thicker ligament than we do, because of how it's evolved. So how do we injure it? Well, anybody can injure their cruciate ligaments. So an elite athlete, Virgil van Dijk, can injure his knee if it's wrecked by a pretty psychopathic goalkeeper like Jordan Pickford coming through on him. But we also see it in weekend warriors, and there are certainly high-risk groups, which we'll touch upon later on in the discussion. It usually occurs in a competitive as opposed to a training environment, and frequently it's a rapid turn, a push-off and twist, maybe an awkward landing on one leg, off balance, a deceleration, or hyperextension. Sometimes it can be really quite innocuous, and people can't believe the damage they've done in such a simple movement. Most commonly, as we'll also mention, it doesn't involve a heavy contact or collision. So the picture in the middle here demonstrates the position of a knee, often when it's torn, with the foot flat and twisted out. The knee falls into a position that we often call valgus, with it buckling down and in on itself, and at the same time, the hip is what we call abducted, which is taken away from the side. The trunk and the center of mass is often also tilted out of position. A schematic little picture like this demonstrates the twist with the red ligament in the middle of the knee being injured as the knee falls into that position. And likewise, the picture on the right with that foot planted and twisted out, that movement happens and the ligament snaps. So in this sequence of pictures, it demonstrates someone tearing their cruciate. So this, I think it's a Roma player injuring his left knee. There is a little bit of what we call indirect contact. So he's taking a challenge, then the left foot gets planted here and he's off balance with a little bit of light contact, pushing his mass out of position. So he's at what we call an at-risk position. And you can see here the knee buckling and tearing the cruciate ligament. Another example here, which is completely without contact, which is a very, perhaps the commonest mechanism that we see. So this yellow kitted individual, player number 6, is planting his left foot and he is being deceived. The player has kicked the ball out to the side, which he wasn't anticipating. The left foot gets planted, the knee buckles in, and the cruciate ligament tears. These sequences show a little bit more contact, and on the left side again, it's the yellow kitted player, and it's his left knee that gets injured. He's suddenly having to change direction very quickly to react to his opponent. The left foot gets planted, he puts his right foot out, and the left knee is in a vulnerable position with the foot way outside the center of his mass, and the knee falls into valgus, and just like in that skeleton picture earlier, and tearing his cruciate ligament. And this sequence on the right is a bit more contact, and on this individual, number 8, it's his left knee. Again, the leg is planted, contact comes on this occasion, forcing it into that bad position, and the cruciate ligament tearing. These are video clips. So this top right picture is Joe Cole, just highlighting very clearly the mechanism we've just been discussing. The right foot gets planted, and he buckles in and out of position. Similarly, on the bottom left, a basketball player, there is no contact, but he is reacting to his opponents. The left leg goes down, and he immediately recognizes he's got a problem. Bottom right is a bit different. This is contact, and anything can happen. So it's not just the ACL sometimes that's torn in these kind of collisions. And although our talk today is purely about the ACL injury, it's not uncommon, probably in at least half of individuals, to have something else going on from a collateral ligament or a meniscal cartilage damage or bone injury. And in the top left, it's Conor McGregor tearing his own cruciate ligament, happens at around the 18-second mark. His foot is caught in a hold. He tries to pull it out himself and manages to tear his cruciate ligament. So what does the individual then typically say? Well, usually the history is of a sensation that the knee popped, the knee buckled, the knee went in and out of place. And generally there's an immediate issue, severe pain, patient collapsed on the ground, often then having to be helped up and off the pitch. Sometimes it's a fairly innocuous thing and people feel they might want to try and continue and they get to the sideline and don't feel too bad. But usually then they try to run again and immediately recognize that this isn't going to work out. Generally over 24, 48 hours, the knee looks quite swollen. There's pain on weight bearing, patient is limping, and may even need crutches for a couple of weeks while things start to settle down. The knee then can actually start to settle and feel pretty good again in day-to-day life fairly quickly over that first week or two. But by then the patient has usually sought some advice via their club physiotherapist, maybe going to A&E for an assessment or visiting their GP. The initial examination, in my experience, can sometimes be difficult if the patient is swollen and sore and guards. So an MRI scan is generally indicated. So most individuals with a history that we've outlined there should really have an urgent or semi-urgent MRI scan. Some patients are told that their knee is too swollen to scan, or we wait until the swelling goes down. I don't think that's usually necessary, and I think you should just crack on and get the scan as soon as possible. So what does it look like on a scan? Well, the left-hand picture here shows a very clear black ribbon structure crossing the joint, joining, as we saw in the pictures earlier, the femur down onto the tibia. And the middle picture shows a ligament that's torn. There is no structure here. You can perhaps see the beginnings of it, but it doesn't continue and extend across the joint. And this picture on the right again shows it in a different sequence on an MRI scan, showing these black lines being the ligament that's torn and ripped off the bone and losing their tension. So that would be, again, features of a complete ACL tear. And an MRI scan is a very accurate way to discern this injury. How common is it? Well, it is actually quite common, and probably the commonest significant knee injury that we see. It's very difficult to get good incidence data in Ireland and in the UK, but inferring from other big studies and epidemiological investigations around the world, you could equate it to about 4,000 ACL injuries across Ireland per year. But obviously that is going to be in a specific age group, with the majority occurring between the ages of 12 and 35. This study is interesting, looking at high school athletes in America, and gives us again a good idea of how common this injury might be. So they looked at 10 studies that had assessed high school adolescent male and females involved just in sport through their schools and local clubs, not in elite activities. And they found if you follow an average adolescent sporting female through the course of a year, who may go from their soccer season into their basketball and lacrosse season, and that's training and playing, they accrue an annual risk of an ACL injury of about 2.5%, which is obviously clearly quite high. And this risk is a bit higher in females than males by an order of about 1.6. And there are seemingly some reasons for that, but we won't go into that too much today. There is, again, a difference between looking at an adolescent amateur athlete and comparing that to somebody who's involved in very high-level elite sport. And actually, the relative risk of an elite, say, Premiership footballer tearing their cruciate ligament is actually relatively low. And this study looked at 28 teams in elite European soccer, so Premier League, Bundesliga, Liga, etc. And really the risk is quite low. So a standard male squad would probably only get one ACL injury every couple of years. So that's clearly going to be quite different to an amateur teenage type individual. And these individuals are clearly special, they're self-selected, they're robust, they're strong, they have anatomical maybe benefits, and are probably involved in injury prevention type programs. In the clinic here, we have a registry which we put most of our ACLs into so we can look at data and follow up results. We found that the mean age, and this is at least, we've probably got at least, I think it's about 6,000 individuals now on that registry, but a mean age of about 25. But importantly to recognize here in the red circled group, at least a third of our individuals are actually under the age of 20. We do operate and see more males than females, but that just reflects that males are more intensely involved in sport, generally in terms of numbers, than females. Again, talking about the mechanisms of injury, as we've already mentioned, the non-contact injury is far more common than contact, and most of these injuries are occurring in competition as opposed to training. The distribution in sports in Ireland is fairly unique compared to some other countries because of the amount of contact in field sport that is played. So at least 80% of our injuries are occurring in field sport, with the highest number being Gaelic football, second highest number being soccer, followed then by rugby and hurling. Other ones, then a minority, snow sports, just simple accidents, etc. So it's clearly a problem, particularly because this tends to be an issue of young and very physically active individuals with high demands who want to get back into sports. It can be quite debilitating and life-changing for people, and it does have the potential also, which we'll touch upon now, for some long-term consequences. We have a lot of high-risk sports in Ireland, and not everyone is the same. So we do have vulnerable risk groups, and you can't necessarily equate an average weekend warrior who is 16, 17 to an elite high-level sports person. So you've seen somebody and maybe come to see somebody then like myself, an ACL is torn, what happens next? Well, we'll discuss the options. And it's a responsibility then really to advise and give that individual a perspective on this injury, not just from the short term, but also the long term too. In the short term, what we're going to be trying to do to that knee is restore confidence and allow them to hopefully get back into their sports and activities with no instability. In the long term, though, we do just need to counsel about the potential still for problems down the line. So there are three main stakeholders here with this injury. Obviously, the primary one being the patient. And in my experience, most individuals really just want a few things clear in their mind. They ask me, can you fix it? When are you going to fix it? They ask me how long I'm going to be out for. And that's pretty much all most individuals are going to be interested in. Physiotherapists, though, will be very important. They're going to have appropriate rehabilitation pathways in place. They're going to be able to give guidance as to what's appropriate and what's not appropriate at various stages of the rehabilitation and guide that individual along the way, hopefully to a successful outcome. And the surgeon clearly needs to make the diagnosis, have a good ability to interpret what we're seeing on the scan and when we examine that patient. We need to talk about what surgery may suit that individual and have a good, reliable procedure to give the best possible outcome. And the problem with an ACL that's torn, as we've mentioned, is the knee gives way. Unfortunately, it doesn't have the ability to regenerate itself like some other ligaments might, and it doesn't have the ability really to heal. So that person usually reports a sensation of instability, not necessarily any pain or stiffness. The majority of patients that I see clearly are going to want to resume their activities, and we start thinking about options, particularly surgery. But some individuals don't have sporting goals, but they still need a robust, stable knee for their job, such as a guard or people in the military, people with construction type works and manual labour, farmers. So even if they don't want to go back to sport, we'll often then still talk about the role of surgery. This video, if it works here, just demonstrates that instability on somebody under the anaesthetic just before they're about to have their cruciate done. So this is a manoeuvre called the pivot shift. What we're doing is we're trying to reproduce the motion that happens. So as the knee is bent, it kind of clicking, you'll feel it gliding in and out of place. And that's an indication that the knee is unstable, as is this test, which just has the cruciate ligament front to back. So is an operation always necessary? No. So non-operative treatment can be reasonable to offer in certain scenarios. That might be someone with lower demand, somebody who's a little bit older. So for example, if I tore my cruciate in my mid-40s, I don't play contact sport or football anymore, I'd probably see how I went with a good rehab program first, strengthening for 3 to 6 months, and only then undergo the surgery if I failed that. If I was in my 20s and 30s or teens, I'd just get on, I think, and get the surgery done as soon as possible. Some individuals are not in a position where they can commit to the time out and the rehabilitation, and that procedure then can be safely postponed and delayed as long as they commit to a bit of gym work and take on board some of the do's and the don'ts. If you do go down the route though of non-operative treatment, some studies have been done on this and demonstrate that at 5 years, even with rehabilitation, at least half of the individuals have elected to cross over and get their ACL reconstructed. But these are very difficult studies to do because it's very difficult to get a set of, 1,000 young sporty people who've torn their ACL and split them in two according to who's going to get their cruciate ligament operated on and who doesn't. But it's as good as it gets here, this study, and it does demonstrate really that there's a very high level of failure, and most individuals will end up electing to get a cruciate ligament procedure. There are also much higher cartilage tears and interventions for cartilage tears over that period of time by a factor of about 13. So in the majority of young individuals wanting to return to sport, I'll talk to them about an ACL reconstruction because the return to sport rates are good and most individuals will get the outcome we want. So these two pictures here are arthroscopic pictures showing what a knee looks like when I first put the camera in. There is no cruciate ligament attaching the bone here below to the bone above. And then this is a picture when we've put the graft in place. So this is the ACL reconstruction. So how do we do it? Well, we harvest something called a graft. And there are two main options that I will discuss with patients, although predominantly I use this graft called the patella tendon. So we harvest a bit of tendon from the front of the knee to get a new ligament that we can then feed into the joint. These are hamstring tendons, that's the alternative. And again, we construct them, stitch them together to make a construct like this that can again be fed into the joint and hopefully then become a new ligament. So just in a nutshell, I'm not going to go into this in any real detail, but what we then do is clean out the old cruciate. We drill tunnels up into the bone, and that graft that we've already harvested, we then have to pull up and pass into the joint. What we're then hoping is the graft takes on board the role of the original ACL and heals, but this is a slow process that can't be sped up. And this is a biological healing time, and even in the best case scenario, the whole thing takes a minimum of 9 to 12 months to try and get the best results. So that's how long you'll tend to see a Premiership footballer out, and that's how long your average Joe is going to be out for as well. And there's a lot of hard work to do in the gym while all this healing is going on. So this brief video here, just skip it a little bit, just shows me pulling up a tendon graft into the joint, into the tunnels. So this is the pulling sutures. The graft is going to come up from the tibial tunnel that I've drilled down below. So these are the things coming in. This is the device we use called a button to fix it in place. And this is actually a hamstring graft. So you'll see it now suddenly pulling up as I pull up into the joint. So this is the graft itself being fed up into the joint, and we're pulling it into that tunnel we've drilled. So this is so I know how far to pull it in, and that's now the graft locked into place. So it's spanning the joint, has to heal up now into the bone above, has to heal into the bone below. Blood vessels will grow into it, nerves will grow into it, and the whole process, as I said, is quite prolonged. So our registry is pretty reassuring, and the good news is that most individuals are going to get back into play, as we hope, in the region of 85%, and that would be in keeping with lots of other studies that have performed around the world, and in fact better than some. Now, re-injury is an important topic because that can be devastating, not just for that individual in the short term, but also can unfortunately be the end for some people in terms of their sporting involvements. Although we can often do another ACL reconstruction, what's called a revision, it's not necessarily always easy, and the results are not going to be as good. Some individuals, though, will get back into it. David Pocock re-injured his knee after his ACL reconstruction very early, I think in his first game back, and then got back into it again. So he was out for the best part of 2 years, 2.5 years. You know, anything can happen in a tangle like this on a GA pitch. You can be good for a year, you can be good for 2 years, you can be good for 5 years, and then something like this happens and you can re-tear. And then some things are just unlucky, like the recent Munster player who just landed awkwardly, I believe, in a line-out and re-injured in his second game back. So it's of particular concern in our younger age groups and cohorts, and many studies have looked at this, such as this one here, demonstrating that patients under 25 may have a secondary injury rate of at least 23%. And if you look at this is an Australian group who've looked at their results, and in particular men under 18 in their cohort had a very high re-injury rate in sport over the first few years, of about 28%. And that's on the same side. If you add in an injury to the other knee, which again, unfortunately can sometimes happen, overall, at least a third of individuals have a re-injury, which is worryingly high. Long-term consequences are important just to counsel individuals on, because what we're giving people is not a normal knee. The cruciate we're putting in is not as good as nature intended. It's usually good enough, gives a good function and outcome, but there are still potential problems down the line, and that's that of arthritis. These individuals, even 20 years later, are still quite young and active, and it can have a significant implication when we're starting to see bone-on-bone type arthritis developing at a young age. And I would have done several knee replacements just in the last few months on men generally in their 50s who may have had a cruciate ligament in their 20s. And these studies back that up. If you look at individuals maybe 20 years after they've had an ACL injury and reconstruction, and you x-ray them, you'll see at least 40% are showing signs of early arthritis, and about a quarter of them are getting symptoms. And looking at how common it is to get knee replacements, if you look at 15-year results, about 1% of people, unfortunately, have already had a knee replacement against uninjured group, which would be much lower. So ideally, clearly, it would be nice if we can prevent ACL injuries. Now, it's never going to be zero because of the unpredictability of contact sports. But there are studies that have been done and programs that have been instigated that show that we can actually reduce the injury rates, particularly in our younger athletes and younger female athletes, by in some circumstances and studies up to 50%, which is clearly very significant. Unfortunately, it's quite difficult to get buy-in sometimes for these types of programs, and that would be another talk in itself. But they are out there, and they can be effective. And these are mostly going to target things that our strength, conditioning, and physiotherapy team will talk about, improving strength, improving movement patterns in particular, called essentially what's called neuromuscular training. Two big studies here demonstrating, as we talked about, this study looking at 18 different interventions showing a reduction from 1 in 54 to 1 in 111 with one of those programs in place. And this is a big study looking at thousands of individuals, and that's in young females. And then there is a good program called the FIFA 11 Plus program, which again has shown significant reduction in injury rates. And this isn't just cruciates, this is also hamstring tears, it's groin problems, it's ankle injuries, if it's instigated into a training schedule. So if you're interested in that, it's fairly straightforward. You can just Google FIFA 11 Plus and you can download these PDF and manuals and printable sheets on all the exercises. And they're very good explanations, little video clips and diagrams of how that can be incorporated into a club's training program a couple of times a week at least. And it's offering a very good warm-up because it does seem sometimes that injuries can happen earlier in games, which is a bit counterintuitive because you'd think you might get tired and get injured. But a lot of these injuries can also happen quite early in the games. And if you get a good warm-up done, which isn't just a simple couple of stretches, it would be useful, I think, to look around if you have children and things in clubs, whether they can introduce that into their team. So just finally, a few take-home points. This is a common knee injury. A third of our patients, unfortunately, are young and under 21, and I'll tend to offer an ACL reconstruction to these individuals who are demanding, wanting to get back into these sports, to try and give a knee that's more robust, give them more stability, and allow them to return into the sports they love. Hopefully also going to be able to reduce further damage. And the majority will get the outcome we want, with a stable knee, and get back into activity. The surgery, though, has to be individually based, and that's a decision and a discussion that I'll have with the individuals in the consulting rooms. And I think it's important that everyone needs to appreciate and understand, and this is important for the patients, and it's important for parents of individuals who have injured their knees, important for physiotherapists, and important for GPs to appreciate that prevention programs that exist do seem to work and probably are underutilized, that we do perhaps underplay a little bit the prognostic implications of ACL tears because of the increased risk of osteoarthritis. And we also always need to counsel, and I'll tell our younger individuals that this can be a problem, that secondary injury rates, either to the same knee or the other knee, can be quite high. So all around, a fairly significant injury, which we have good procedures for, but there are issues that need appreciating and understanding. Now, hopefully that wasn't too difficult to take on board, and I hope there are a few points that people have taken home. That's it. Many thanks. Thank you.
Thank you, Mark, for joining us. I know you've just come out of surgery as well, so we'll work away with these questions. Now, a lot of the questions are similar that people have asked, so we're going to kind of join them together. So one of the questions is, after an ACL reconstruction, how long does it take to return to field sport?
Yeah, so that's often one of the very first questions that most people who have this injury are going to ask. And generally, it's important, I think, for people to realize it shouldn't be time dependent. So there is a kind of a biological healing phase, which everyone has to go through. It doesn't matter if you're a Premiership footballer or that sort of weekend warrior. So there is a ligament healing time. Yeah. But after that, you shouldn't be thought of as time dependent. In time past, it always used to be, oh, you can go back to play at 6 months. But we've kind of moved away from that because of the realization that most people are nowhere near ready at 6 months. Yeah. I tend to recommend a minimum 9 months. And at 9 months, there's an assessment. Obviously, there's a clinical assessment from my perspective. How does the knee look? How does it feel? Is it stable? Swelling? Is there pain? Is the movement good? So that's the surgical kind of assessment. Yeah. But then there's obviously the tests that we'll often arrange for individuals. So that can be strength scores, seeing how they are for their body weight, seeing how symmetrical they are between legs, and also getting them to do simple tests like landing tests, hopping tests. And very few people are actually ready at 9 months. Okay. And there shouldn't be a rush, in my opinion. And this, I guess, will tip into some of the other questions, I think. Yeah. But particularly in the younger individual, they've got everything to lose and nothing to gain by trying to go back at 10 months rather than 12 months or 15 months or 18 months even. So the earliest is 9. I usually say you can aim to get back between 9 to 12 months. And that's the same if you look at the Premiership footballers. They're all 9 to 12 months. You're very rarely going to see anybody returning to pitches before that. And they're obviously treated in the gyms every day by elite rehab specialists. And so if that's what they need, that's what everyone else needs.
Yeah. Yeah. And then the other questions that people are asking about, especially if they've had young teenagers who've already had ACLs, the risk of them going back to competitive sport, they're worried about re-rupturing the ACL or rupturing the other ACL. So what is the likelihood that they'll get back to competitive football, I suppose?
Yeah, so a bit like in the talk, I mean, the chance they go back is good. Yeah. But unfortunately, the chance of re-injury in that age group, particularly the under 21-year-olds, is quite high. Yeah. So going back to the original point, that there shouldn't be any rush. They need to tick all the boxes. And I can see someone there who said that their son has done all the tests here in the clinic and passed with flying colours, but is still a bit apprehensive, and that's quite normal. And there are psychological things and barriers that people have to go through as well if they've had sequential injuries at a young age. Clearly, there's never a day when there's no risk, ever. And there are some things you can change and some things you can't. Yeah. So you can't change your genetics. You can't change the shape of your knee. You can't change your collagen, which is what your ligaments are made of. And it's not unusual. I've operated on twins, brothers and sisters. I've operated on mothers and daughters. And there are sort of things you cannot change. And if people are getting sequential injuries at a young age, it is a concern. If it was one of my kids, I'd let them go back as long as they were doing well. Mm-hmm. If it started happening again, onto another injury, then you have to sometimes really think about how sensible it is to carry on in those sports. Yeah. Mark,
thanks very much for that. And thanks everybody for joining us tonight. So if we still have some questions there, but what we'll do is we'll send you back emails of those tomorrow from Tommy and Luke as well. And keep an eye on our website for any future events that will be coming up in 2022. And we will be sending you out a link for the talk tonight. So if anybody still hasn't seen it or they want to watch it later, it is available on the website. Thank you.